Welcome to conference. My name's Choudhury. A lot of you know me as Sai. I'm one of the PGY-2 EMIM residents. So I guess I'm starting off with a small talk today on chest pain. I also just wanted to say welcome to all the interns. I haven't met you guys, most of you guys, but I hope you're excited to be here and I'm excited to work with you all. So we'll jump right into it. So chest pain. And I want this to be interactive, so there might be points where I'll ask for some audience participation. You can raise your hand, call out. I don't have any preference. Okay. So we have a 47-year-old male, past medical history of hypertension. They kind of just rush him into CCT, and he's complaining of intense substernal chest pain. Started around 90 minutes ago while in the shower, unable to rate intensity of the pain associated with dyspnea. You have some vitals that you see here. I guess kind of just start off, what are some life-threatening diagnoses that we're thinking about?
ACS,
Right? Good. Yep. Okay, right. Anything from a trauma? Right, there we go. Let's do one more. Okay. Someone said GERD, kind of along that. You could have like a perforated peptic ulcer. So there's so many that you can go through. These are just 6 common ones. So now we want to see what the EKG looks like, and that's what we see. Does anyone want to take a stab at this?
and ABL, E2, and which I feel like reciprocal changes in 3 and ABL.
Okay, yeah. So kind of just like, thank you for the participation, Ryan. Kind of just going through it. It's like normal sinus, around 75 beats per minute, normal axis, normal intervals. And then as Ryan mentioned, we see some ST elevations in lead 3, AVF, and then we also see some depressions, reciprocal changes in lead 1 and AVL with a T wave inversion. And then we also kind of see some SE depressions with T wave inversions in V2. So this was the initial EKG, and I think Dr. Willis brought this patient over from triage to CCT that day. So yeah, today we're going to be talking a little bit about chest pain, specifically like, STEMIs, a little bit of brief review. A lot of times when we're talking about these patients, we look for like risk factors, especially in a lot of the scoring. So this is kind of like a diagram just describing a little bit of pathogenesis, right? Atherosclerotic disease due to formation of fibrofatty plaques. And you can see here, lipid particles. So people with hypercholesterolemia, diabetes, as disease progresses, you get more inflammation and upregulation of certain inflammatory cytokines. And then you also attract inflammatory cells that kind of oxidize and phagocytose these lipid particles, and you get this plaque that forms. And then over time, if you have hypertension, for example, you'll have endothelial injury, and that can also lead to thrombosis later. Typically, when we're talking about type 1 MIs, we're talking about rupture of a plaque that can embolize distally, or you have thrombosis forming. And then also kind of just going over a little bit of some of the hemostasis pathways involved, because a lot of the treatments we use target these pathways. If you guys remember your coagulation cascade. So once the plaque ruptures, we have a platelet plug that forms, and then these platelets will be activating other platelets through primary hemostasis. And then we also get stabilization of that through the coagulation cascade, extrinsic pathway, intrinsic pathway. And together we get this platelet plug with this fibrin mesh clot. So there's a definition for STEMI from the horse's mouth. It's new ST elevation at the J point in at least 2 contiguous leads, at least 2 millimeters or 0.2 millivolts in men, or 1.5 millimeters or 0.15 millivolts in women in leads V2 or V3, and it's a little bit less in other leads, and it has to be in at least 2 contiguous chest leads. And then majority of patients will then have some evidence of Q wave infarction. So on the left, you can kind of see Q waves with ST elevation. And we're talking about the J point. It's this point right here where the QRS complex ends and it starts turning into the T wave. And what we're comparing it to is this TP segment preceding. So these are all signs of STEMI on the left. And then on the right, these are kind of ST elevations that you might see, but it's not because of occlusive MI, it's because of pericarditis or Brugada or bundle branch block. And in the middle, I kind of found this nice figure from Amboss. So this ST segment elevation is typically supposed to represent transmural infarction, right? So you have the epicardial vessels running on the outside of the heart, and they supply blood, I guess, into the heart. And when we have myocardial ischemia, the first place to get ischemic is the subendocardium. But once you have complete occlusion, then the entire myocardium gets ischemic and infarcted. Oh, and yeah, that's what the ST elevation here is representing, and then other signs of ischemia on EKG, such as T wave inversions, ST depressions. So initial management, you want this patient in the resus bay, you want cardiac monitor, IV O2, you want access labs. I know we all learn like Mona Bash in med school, so you don't want to over oxygenate patients. Only give them supplemental O2 if they're hypoxic. You want to give them pain control as well. A lot of times we forget about that. Opioids are better than nitrates for analgesia, so start with that first. If they're nauseous, you want to give them antiemetics. If there's concern for acute pulmonary edema, you can give nitroglycerin, or if their pain is not being controlled. And then there's also antiplatelets, anticoagulation, and then you should have a reperfusion strategy, right? The problem is the myocardium isn't getting perfused. So what's your strategy? And that comes down to, are we going to do PCI, fibrinolytic? And then you also want to call code heart, right? Because you want to get the consultants on board, everybody, nursing staff, and other physicians. So kind of coming back to EKG changes, as Ryan mentioned, right? He saw some changes in the inferior region on EKG that corresponds to the inferior region, and then he saw reciprocal changes. So a lot of times that's what we're looking for, right? You might have ST elevation, but you also want to look to see if there's reciprocal changes, and a lot of times reciprocal changes might happen first. And I found this diagram online. I think it's kind of helpful in visualizing the coronary vasculature as well as different portions of the heart and the leads that correspond to that. Now, inferior STEMI has diagnostic criteria on EKG, right? You're looking for ST elevation leads 2, 3 AVF, also reciprocal ST depressions in AVL. And then if you see Q waves, you're even more concerned. You get a worse prognosis if there's RV infarction. So you want to pay attention to the patient's vitals, right? Are they getting hypotensive on the EKG? Or is their heart rate slowing down? Do the heart block? Do you see signs of extension into the posterior myocardium? There's also, a lot of our discussions around heart attacks around STEMIs, but recently we've been talking more about OMIs, which is occlusive MI. And in cases when you're using the OMI paradigm, a lot of time ST depression AVL is more prevalent than actual ST elevation in the inferior leads. And so that's something to be aware of. Now, there's an artery called the posterior descending artery, the PDA, and it supplies the inferior part of the heart. Now, when we say someone's left versus right dominant, we're talking about where does the supply come from? So most people are right dominant. So a lot of times this artery is coming off of the right coronary artery. But in some people, they could be coming from the left circumflex or co-dominant. So when we're talking about an inferior MI, there's signs on EKG that can tell us if we're worried about right ventricular involvement. Right coronary artery occlusion versus circumflex occlusion. So if you have an ST elevation in lead 3 that's greater than lead 2, if you have presence of reciprocal ST depressions in lead 1, or if you have ST elevation in V1 and V4R, those are all signs of right coronary artery occlusion. If you have ST elevation that's equivalent between lead 2 and 3, or absence of reciprocal ST depressions in lead 1, or ST elevation in the lateral leads, so lead 1 AVL, V5 to V6, then those are pointing more towards a circumflex, so left dominant heart. So if we look at that EKG from the beginning, to me, this looks more like ST elevation is greater in lead 3 than lead 2, and we also see some ST depression in lead 1. So how do we get these EKGs, right? If we're concerned about extension into the posterior wall or the right ventricle. So when it comes to posterior EKGs, you can kind of just take V4, V5, V6 and move them over to the posterior left side and line them up like this along the scapula. And this will give us a view of the posterior side of the heart. If we want to get a right-sided EKG, the most specific lead to kind of transfer over is V4, and you can move it over to the right side of the heart, and that can give you a picture of whether there's RV infarction going on. So why is this important, right? Posterior infarction can accompany around 15 to 20% of STEMIs, and they usually happen in the setting of an inferior or lateral infarction. And an RV infarction can complicate up to 40% of inferior STEMIs. And so you should always get a right-sided EKG on all inferior STEMIs. And again, these patients are very preload sensitive because the right ventricle isn't contracting, and they can get super hypotensive in response to nitrates or analgesics, for example, like morphine. So if you do have hypotension, you should be giving these patients fluids. So we ended up getting a repeat EKG a little while later. Does anyone want to try to take a stab at this one? Yep. So Felipe said inferior posterior MI. So you see some subtle ST elevation in V7 and V8, and all you need is half a millimeter, and that counts. Okay. 70 minutes later, we got another EKG, and I think you can see the progression going on. So these ST elevations in the inferior leads are much more pronounced. You have much more ST depression in the inferior, in the anterior leads, which kind of tell you that there's posterior ischemia, and then again the posterior ST elevations. So at this point, you ordered labs earlier. What labs did you order? I forgot to ask that. Troponins, right? Anything else you guys would want to see? Right, right. Is there a particular reason why you're concerned about the potassium? Right, right. So in the peri-infarction period, like one of the most dangerous things is malignant dysrhythmias. We actually had this patient go into VTAC a few times. It was not sustained though, thankfully, but we had pads on. We were ready in case a patient became unstable. So here's some of the laboratory work that came back. Of note, this patient did not have a positive troponin. So at this point, you have EKG changes, you have someone in chest pain. What are we going to do? Transfer, right? Because we don't have PCI here. So when it comes to guidelines, right, this patient came with acute chest pain. It's very intense for concern. Some dyspnea is associated with it. EKG shows, signs of ST elevation. And we think it's probably due to underlying heart disease. So now we have to follow the STEMI guidelines. But if there wasn't STEMI, there are other things that you should evaluate for, which I'm not going to be discussing. The most recent set of guidelines about managing STEMI are from 2013. So it's been 11 years. Well, basically, we have to figure out a reperfusion strategy, right? So at Kings County, we're a non-PCI capable hospital, so we're going to be going down this path. And when you read a lot about STEMI management, there's a lot of different time metrics that they care about. So you've heard about door to balloon time, for example. Here they care about door in, door out time because the patient has to be seen at one hospital and then sent elsewhere. So in that case, transfer for primary PCI, and this says FMC. So FMC means first medical contact. So it's not when the patient walks into the hospital. It might be when EMS sees the patient. And so the standard of care is getting them to a PCI capable facility in less than 120 minutes. But if you're concerned about being able to do that, then you should do excuse me, fibrinolytic agent within 30 minutes of arrival when you anticipate that it's going to be taking longer than that, and then transfer them out. So here's the timeline of our patient. They came in around 11:51, and by the time we got them out the door, it was 2:30. So the overall door in to door out time was not 30 minutes, it was 159 minutes. And other metrics, door to EKG time, 26 minutes, EKG to when we started antiplatelet therapy around 37 minutes, and then EKG to anticoagulation time around 50 minutes. So initially we called Bellevue to get this patient over there for PCI, and you can see it takes about 1 o'clock in the afternoon, anywhere from 55 minutes to an hour and a half. And so this patient was going into VTAC, their their EKG was showing STE changes, and so we called Maimonides to try to arrange transfer there. And then this started to happen, right? So thankfully it was intermittent and the patient was okay, but there are several complications of ST segment elevation, right? Arrhythmias, cardiogenic shock, you can have formation of thrombus due to hypokinesis of certain parts of the heart, and then pericarditis as well. So when it comes to indications for fibrinolytic therapy, again, similar to how we have a certain time interval for strokes, so here the recommendation is 1, which means there's likely overall benefit and class A evidence. If their chest pain started within 12 hours, then they're a good candidate for that. If there is a harm associated with it as well, if they have ST depressions, except if it's a posterior MI, or when it's associated with ST elevation and AVR, there could be a harm with it. There are some contraindications, right? You guys can kind of infer some of them, right? If they've had a recent stroke, recent bleed, if this patient is dissecting. So there's a list up here. Does anyone remember what the vitals were for this patient? Okay. So in that case, what would you have liked? What would you have wanted to get? And right, there we go. And this is what the chest X-ray looks like. So on the left was 2 months ago. This was from a PA and lateral. And then on the right is in CCT that day from a portable. And so there was a certain point of where we were discussing from the cardiology console whether we should give TPA. But I guess there's enough concern that this patient could still be dissecting, so it wasn't given. Kind of going on to some of the therapies. I know when we were trying to start the patient on heparin, the cardiologist wanted 5,000 units, but we weren't able to give more than 4,000, and this is kind of where it comes from. So these are recommendations for anticoagulation and antiplatelet therapy if you're going to be giving a fibrinolytic, which we ended up not giving. So that's why if you see cardiology ordering, 600 milligrams clopidogrel or 5,000 units of heparin, they're basing it on the assumption that this patient is going to PCI right away, or is going to get PCI right away. So some interesting topics about this. Ultimately, the patient was transported to Maimonides, and we don't have access to their records, so I don't really know what happened. But this case kind of just got me thinking about, how we're treating STEMIs. So I found like a recent like meta-analysis from a couple years back. It's describing like the pharmacoinvasive approach. So when you do fibrinolysis at a place that doesn't have PCI and then transfer them for PCI, depending on the timing, it has different names. So if you can give them fibrinolysis and get them to PCI facility in less than 120 minutes, that's called facilitated PCI. If it takes more than 2 hours, that's called a pharmacoinvasive approach. Now, this study found that primary PCI is a standard of care, but uh, if timely PCI is not available, then pharmacoinvasive approach is safer and more effective than facilitated PCI or fibrinolytic therapy alone. The other thing was this patient had a negative troponin. Does that mean that he wasn't having a heart attack? So around 50% of all STEMI patients will have a low or undetectable troponin at the time of presentation. So that's just because they have a negative troponin doesn't mean they're not having a heart attack. What this study found was that troponins might be helpful, admission troponins might be helpful in understanding how our pre-hospital management of STEMI is, because the greater the troponin on admission, the greater the mortality risk of death in their overall care. The other thing was, if you looked at that timeline, we didn't give our patient any pain meds. And I think that's really important because everyone should be getting analgesia. So there's a little controversy around morphine, whether it interacts with some of the antiplatelet or anticoagulation medications. One study says it does, but from I believe this is from the American Heart Association. They did their own meta-analysis, and they said overall there was no change in like major adverse cardiac events at 1 year. The other thing is as we discussed, we couldn't have given morphine to this patient in the sense that if there was right ventricular involvement, that would further tank their blood pressure. But what we could have done was fentanyl, and you can start with 25 to 50 mics and titrate as needed. So take home points, troponins can be negative. At times, the only way you can tell someone's having a STEMI is by seeing serial EKG changes. Get the right side of EKG if you see an inferior STEMI, where almost half of inferior STEMIs will have right ventricular involvement. Remember the standard of care, right? Door to balloon time, 90 minutes. Here, it would be 120 minutes because we don't have PCI here. I think fibrinolytics should be considered, given no contraindications. If we anticipate that it's going to take longer than 120 minutes, and then a lot of the antiplatelet, anticoagulation medications that we give, remember, they're given under the context that the patient's going to get PCI in less than 2 hours. And then don't forget to treat your patient's pain. Start with morphine or fentanyl. And then I forgot to mention this earlier, but you don't want to give them NSAIDs as well. That is associated with an increase in major adverse cardiac events when given with dual antiplatelet therapy and anticoagulation. Any questions?